This conference will now be recorded.
Okay, we're ready to get started. Thank you everyone for joining us. This is our fourth CANOC and WHRP workshop, and today we're going to present and discuss about Statistics 101. And this is, again, one of my favorite presentations to try to simplify statistics as much as possible. So let's get started. I'd like to start by acknowledging the traditional owners of the land on which we meet across Canada, and it's the land of First Nations, Inuit, and Métis people known as Turtle Island. And we're all lucky to be living on in such a beautiful land. I'd like to acknowledge our funders, participants of all of our studies, our staff. Some of you are on the call. You work really hard. Thank you. Our students, and many of you are on the call. You're an essential part of the team, and that includes our community scholars and our many partners and collaborators. This is my disclosure slide to let you know where I have obtained funding in terms of from industry. I believe there's no potential conflict of interest related to this presentation, and I mitigate potential biases by always preparing the slides myself. For this presentation, I am again going to do my favorite part of research, which is briefly review what we discussed in our first workshop, which is how to develop a research question, and then take that to the next level, which is review some basics of statistics. Does that sound okay with everybody?
Yes.
That sounds great.
Okay. Okay, so if everybody remembers, to me, spending the time to really develop a well-built and solid research question is a really important step of research, if not the most important step. The clearer your research question is, the easier all the future and next steps will be of your research project. A well-built research question has 3 to 5 components, and it's usually in the format of PCOT, which we'll go over. And again, carefully framing of the question greatly improves the quality and the utility of the answer. Why is a research question important? Again, a well-written research question allows you to know what is the best study design and what to do next. And so this is what PCOT stands for. The P is for what your population is. So it's the overall population. Sometimes the population gets confused with what the topic is you're interested in, but that's not what it is. The population is the overall population that you are going to be drawing your analysis from. The I stands for intervention if you're doing a clinical trial, or if you're doing a retrospective or prospective cohort analysis. I think of it as the independent variable of interest. So what are you testing? What are you asking the question about? And the C is for comparison. What are you comparing that intervention or independent variable to? The independent variable in a prospective or retrospective cohort study is linked to the comparison because it's really one variable that usually has a yes/no answer. But in an intervention study, clinical trial, the intervention might be drug A, and the comparison would be either the standard of care drug B or a placebo. So I hope that makes sense to all of you. The O stands for outcome, or in cohort studies, it's sometimes called the dependent variable. and the T it stands for time. So how at what time point is your outcome going to be measured in comparison to the baseline? And there's other aspects to the time that you can consider as well, but that is considered the most important time. Is at what time point is your outcome being measured in terms of the baseline? Do people have any questions about the research, the different components about the research question? Has everyone been working on developing their research question, and that's coming together clearly? So just wanted to open it up now for any questions about this. How about you, Christian? I think you've been working on your research question. How is it coming along for you?
Hi, Mona. I was just unmuting my line because, yeah, thanks for asking me the question. I have been struggling just a little bit because my initial interest was to hopefully do some comparisons between key population groups. And given my background from having more training in doing qualitative research, I think my trouble has been trying to narrow down what would be my independent variable interest and then what my comparison groups may be. I'm still doing some final kind of work to finalize my research question, but I would definitely appreciate your guidance or advice from the rest of the team as well to see how I can actually do some meaningful research question that fits some hopefully my interest, and then also being able to maintain or contain it so that it's manageable and feasible as well.
Okay. So, hi, Christian. It's Tracy. Mona, Christian and I had talked a bit, and I think we're going to try and connect and get together to see if I can give any recommendations or anything. I'm more than willing to help them out, but I know other people are kind of good at that as well. But, sometimes getting your question down is the biggest step, and then everything else will fall into place.
Mm-hmm. Thank you, Tracy.
Yeah, so if you don't mind, we can work through it a little bit right now, Christian, if it's okay to put you on the spot a little bit. Usually what I do with that problem or challenge is I start with, I don't know if you can see my arrow on my screen. Yeah? I start with the outcome.
Mm-hmm.
That's my trick, okay?
Oh, okay.
My trick, because if you start with the population and the independent variable and the comparison up here,
mm-hmm.
it actually that's the trouble you're running into.
Okay.
The first three, the P, the I, and the C, overlap, and so teasing them out, that becomes tricky and cumbersome. So what I like to do is I start with the outcome. Okay?
Right.
So what outcome do you think you're interested in?
The outcome is I'm interested in exploring viral suppression, really. So to see if the independent variable and the comparison groups, whether there's any variance in their ability to achieve viral suppression or undetectable viral loads post initiation of ART, and also hopefully to see if they're able to maintain it for 6 months post initiation.
Okay, and what kind of groups are you interested in comparing? Like what is your question in terms of what population and?
Mm-hmm. So the population, I think it would be people living with HIV for sure for the CANOC cohort. I think initially I was really hoping to compare, from a social sciences perspective, like the dominant groups and the less privileged, more marginalized key priority population groups. But I've received feedback from my team, and they have been helping me to refine that. So I'm actually right now just really trying to figure out what um, independent variable of interest I want to uh, uh, set as, and what comparison groups I want to identify as well.
Okay, and then Jill, is the new data cut available?
We have the 2016. Oh, sorry. We have Beverly here. She literally just stepped in the room. Hi, everyone. So we've got the 2016 data.
Yeah, so we have kind of a version 1 of the 2016 data cut that's been ready since October or November, I think. And right now we're just kind of working on getting a version 2 data cut ready. So like we have certain sites that, we had to exclude a lot of patients for certain reasons, and so we're working with those sites to help improve the data so that we can include more people. So we have a few sites that we're working on improving. So I guess the answer is, yeah, we have the version 1 of the data cut ready to go, but based on when people's DARs are submitted, it'll be a decision whether or not we use that version 1 data or whether we wait another week or 2 or however long to use that version 2.
Okay, so I think, Christian, no one has done the viral suppression and maintenance analysis with the 2016 data cut, if I'm correct, Bev. So you could do, you could do what's called an exploratory analysis,
Right.
where your independent variable / comparison group there's many of them. Okay. So,
Yeah.
but then you could pick a few independent variables. Like you could say that your area of interest is around marginalized and vulnerable populations in Canada.
Right.
And so the few independent variables that I'm particularly interested in are, it could be, ethnicity / race,
Right.
could be around age, so youth versus older. I don't know. We do have postal code, and so there is a way to you can take postal code in Canada and divide it up into quintiles of income associated with that postal code. So you could pick 3 to 5 independent variables that suggest vulnerability and marginalization, and have those be your independent variable in comparison. And basically, let's just call it independent variable of interest, and sort of your hypothesis, and then but have it nested in more of an exploratory analysis to look at all of the variables associated with viral suppression.
Right. Mona, I think that's very helpful. Maybe if it's okay as well, because I think I've been actually trying to refine my work and just contain the scope as well. So if I can also send you and Tracy an email after the webinar, within the next couple of days, and get some further feedback, that if that's okay with you, that might be great as well. Yeah.
But then let me ask you a pointed question, if it's okay. If you choose one variable, independent variable, to predict viral suppression,
yes,
what would it be? I know your work, so is it ethnicity? Is it ethnicity, race, or is it income? What is it?
I think right now I am thinking of ethnicity, race, probably. I was originally hoping to see if I can, you know, look at kind of position myself in a way and define, let's say, a privileged group, according to just seeing how
Right.
history has been, right?
Okay.
I was going to say,
Yeah.
perhaps the white MSM group would be the privileged group in a sense, in terms of how the services have been, the resources have been dedicated to that group. But then I think the issue is it becomes quite difficult for me to define the other comparison groups, because they're not necessarily, originally my intention was not to
Okay.
compare them just by race or their transmission risk group. So
Well, here's a possibility. So a possibility for your independent variable is to make something that's called a what's it called? Shoot. Like a compounded variable that includes several things, and you could call it a variable of assessment of privilege, okay, versus non-privilege as your comparison, and that could include ethnicity / race. It could include gender,
right.
risk factor,
And
I recommend. I'm not sure anyone's done this in CANOC, but it would be interesting to include quintile of income, which is determined by postal code.
Yeah, that would be great. And I may also want to consider co-infection, health status as well, to see if there may be any differences.
So then it becomes too many. That you have to limit it. And then, the term is a composite variable. So if you include several variables into one concept, the composite variable. Okay. So that's really helpful. If it's okay with everyone, we're going to use Christian's example as we move through the slides. Is that okay?
It's fine with me. Okay.
Great. Okay. So here we go. Any other questions before we move on? Any other questions about the research question before we move on? No? Okay, let's go. And we have a great example with Christian's project. I really want to try to simplify statistics, because people think it's really confusing, and I don't want to do a project because it's too confusing. But to me, it's really not confusing. The whole point of quantitative research or quantitative studies that we do, and of statistics, is to find whether there's an association between two variables. And those two variables are, one, the outcome. So in Christian's example, the outcome is viral suppression. Okay? Right? And two is the independent variable of interest, which in some cases is called the predictor, and in epidemiology, it's called the exposure. Okay? We are going to use independent variable, and the outcome is the dependent variable. So the whole point of statistics is to see whether there's an association with the outcome, in Christian's case, viral suppression, and the independent variable. And in Christian's case, the independent variable is potentially a composite variable of privilege. Is there an association between those two things? And if an association is found, whether that association is true. That's all statistics is about. Okay, does that sound easy and clear? If you understand that, we can end our whole presentation now. Okay, goodbye everybody. No, I'm just joking. It's really that easy. And how do we assess whether that association is true? We assess by using methods that try to prevent bias, and we try to correct for something called confounding. So bias is a systematic skewing of the data that leads to inaccurate or incorrect results. So let's take Christian's example, okay? So it could be possible that all of the people with privilege have suppressed viral loads, and then all of the people without privilege end up in the study, but really only those that are actually doing pretty well end up in the study, and those that actually don't even come for visits and don't even come to the clinic don't end up in the study at all. So we have missing data for them, or they come into the study at the beginning, so they're recorded in the study, but then we have no more data on them, so it's missing data. So then really all that you have is data on the privileged individuals who are coming for all the visits, and we have all their data, and the non-privileged people who also come to clinic, and we have their data, and really it's not that bad. So the bias is there's systematic skewing only for people that are in care, and we don't have all of the data on people who are really living on the margins of privilege. Do you see that's a potential bias in that study? Does that make sense?
Yes.
In our study. And we want to try to minimize that bias as much as possible. How do we do that? There are, yes. Did anyone have a question? No? How do we do that? There's lots of different ways to do it. And one is in your data collection, to try to have as much data as collected. The way that we do that is to correct for confounders, most commonly. And that's a third variable that correlates with both the outcome and the exposure, and is the real reason for the association. Now, when Christian runs his analysis and he writes up his manuscript, the limitation that I just mentioned will have to be entered into the limitation section, because we cannot completely correct for the bias of not being able to analyze the data on the people that didn't even come to the different clinics and that we don't have data on. Do you understand that? So really, the data that's being analyzed in CANOC is really for a cohort of people who are mostly in care. So the group that is not in care, we don't have data on them, and that's an obvious bias. So we mention that in the limitation section of the manuscript, Christy, and that's how that works. Do you see what I mean?
Yeah.
But we will have data in a spectrum of people who of privilege, with high privilege or low privilege. However, maybe their viral suppression's not related to privilege at all. Maybe it's related to, I'll give you an example. Maybe it's really related to social support, okay? And that if they have social support, that's actually what leads to viral suppression. But if social support is associated with privilege and it's associated with the outcome, it's a confounder, and we have to adjust for that and see which one is really driving viral suppression. Is it privilege, or is it social support, or is it both a little bit? So that's what adjusting for confounding is. Is that helpful?
Very much so.
Okay. I'm back to the components of the research question, why? And you set me up so well, Christian, because the way that I get around the dilemma you had of figuring out what the independent variable of interest is I start with the outcome. And and so here it is. It's important to always identify one outcome. So you didn't have this challenge, Christian. A lot of people do. They are interested in viral suppression, maintenance of viral suppression, death, visits to the clinic. They're interested in lots of different things. So that's a different problem that many people have. And what we try to tell them is it's important to really focus and have one outcome, the most important outcome that you're interested in the study. Why is it important to have one outcome? There's something that we do that's called a sample size calculation, which is we try to figure out if we have enough of a sample of participants to really answer the research question that we're asking. So, and to be able to do a sample size calculation, you use your primary outcome for that. And primary means one, so only one primary outcome. You can have secondary outcomes. So, for example, in your scenario, Christian, your primary outcome is viral suppression, but you have the secondary outcome of viral suppression maintenance, or we also call that sometimes viral rebound. So that's a secondary outcome. Do you see that?
Yes.
The ultimate primary outcome is often death, right? And like in a cardiovascular disease study, they might have death as the primary outcome and then other secondary outcomes. Any questions about that, about the different types of outcomes? I can do a whole presentation on outcomes because there's composite outcomes that we already spoke about a little bit. There's surrogate outcomes. So why do we use viral suppression as the main outcome for in HIV research? Well, the reason is because in the original cohort studies that characterize the natural history of HIV, viral suppression was a surrogate for death. So there are prior studies showing that viral suppression correlates with death. So people, thankfully, don't necessarily die from HIV today. So, but we have evidence from studies done before that viral suppression correlates with death. So that's why we use viral suppression as such an important outcome in HIV. There's other reasons too. If you have full viral suppression, you don't develop drug resistance and so forth. But there's actually reasons why we use viral suppression as the outcome in HIV research. And really, technically, it's what we call a surrogate outcome.
Hi, everyone. Sorry I'm late. Kerrigan.
Oh, hi, Kerrigan. Okay. Okay. What are the different types of outcomes? And really, you can replace. This is another. I'm going to give you this. This is another little trick. It really should say what are the different types of variables, because the outcome is just a type. It's just a variable. The independent variable is another type of variable. So there's. So what are the different types of variables? But I'm going to concentrate on the outcome. So what are the different types of what are the different types of outcomes that we can have most typically? Who can answer this question? Maybe I'll call on Rula.
Yes, Mona.
I think we just mentioned them. We said that there is the like just a simple outcome variable, or you can have a surrogate one, or you can have a composite one. I know in the last paper that we did on resilience, we had some indicator variables for a latent variable. So it wasn't actually an outcome though, but that's a possibility.
Let's take your resilient variable, okay?
Yes.
What I mean by what are the different types of outcomes is like, how is it coded? How was it reported? What kind of variable was it?
Okay, so for resilience, what we did is we did a median. We figured that the median was the best way to divide our sample. First of all, the sample was skewed. Most of the women had very high resilience. And among that very high resilience group, in terms of the sample of women, we decided to take a median to divide them into high resilience and not very high resilience. But overall, they were all reporting high resilience.
And what type of variable?
It's a continuous variable, like
right. So that's what I was trying to get at.
Oh, okay, yeah.
So the different types of variables that you need to, this is what you need to decide is, and this is why this actually is so important, because it dictates also what type of analysis you're going to do,
yes.
what type of statistical tests. So for the example that Rula just gave, she used a resilience scale.
Yes.
It went from 0 to 90.
Yes.
So and so the answer could be 0, it could be 10, it could be 30, it could be 90. So it was a continuous variable. Do you see that? You could have a categorical variable, which is a category. So
yes.
The most common type of categorical variable done in research is a dichotomous variable. So which would mean yes or no. And so that's called a categorical variable, and a dichotomous variable is a type of categorical variable. Another type of categorical variable that I didn't put up there is an ordinal variable. So if your categories have no order, then it's a pure categorical variable. If the categories are yes or no, it's a dichotomous variable. If there is a sort of order to your categories, so let's say age, so let's say you divide age from 0 to 30, 30 to 50, and then over 50, that's actually an ordinal variable because there's an order to the categories. So those are the different types of categorical variables. Rula gave us the example of a continuous variable. And then there are many different types of variables and / outcomes. You can have a time to event variable. And so this is where it becomes tricky for your question, Kristen, okay? What kind of variable do you think you have as for your outcome?
For virus suppression, I think they're categorical, because this either, if I'm just saying whether they have achieved virus suppression or not, then it's a yes or no dichotomous situation. Yet if you're looking at the actual viral load, then I would say they're a continuous variable or time to event variable. Yeah.
Right.
Okay.
You see, it's tricky a little bit.
Yeah.
So often, so if we look at the independent variable in your case, we might have baseline viral load as an independent variable, right? And that will be reported as a continuous variable. So you will report the baseline viral load of 100,000, right, is a continuous variable. But your outcome variable of reaching viral suppression is a categorical variable. Exactly what you said first. So
okay.
Did they reach viral suppression? Yes or no? It's a dichotomous variable, okay?
Mm-hmm.
However, where it becomes tricky is we often do look at viral suppression as a time to event, which means how quickly did they reach viral suppression? So you have to ask yourself which one is more important to you. Is it whether they ever did reach viral suppression, or is it how quickly they received viral suppression? And then for your secondary outcome of viral rebound, we often do that one as a time to event variable also, and we do it by looking at, in the group that did achieve full viral suppression, how quickly did they have viral rebound? So that one is often done as a time to event. And what we do very often is we do all three. We do viral suppression as a dichotomous variable. Did they achieve viral suppression, yes or no? We do viral suppression as a time to event. How long did it take them to reach viral suppression? And then we also do time to rebound as a time to event variable. Okay, so we do all three, and you're lucky, Christian, because CANOC already has the definition of all of those time to events.
Oh, perfect. Thank you, CANOC.
Does that help you, actually, Christian? Does that make more sense now?
Yes, it does. I think I think in terms of the composite variable, and also still trying to formulate the question within the PCOT, what may be how can I define what the independent variable is, and then what are the comparison variables, given that if I'm going to use a composite independent variable?
Yeah, I think a few slides down it'll be helpful. I think I have something that's going to help you.
Okay, great.
But I think for now, you understanding what type of variable your outcome is also helps you. That you're going to use a dichotomous variable as well as a time to event variable for your outcome, and it makes it a little bit clearer. There are other types of variables. So here's an example. You could use an economic outcome. Okay, so you could help economists have different economic variables that they use as outcomes. There's something called quality adjusted life year. You could have a dollar amount. So just to put it out there that there are actually other types of variables also. Mm-hmm. Why is it important to identify what type of variable your outcome is? Well, the type of variable that your outcome is, and Rula already gave this away, tells you what statistical tests you are going to be using for what we call your summary statistics. So when you first start with your statistical analysis, you will be using summary statistics or descriptive analyses. Those are both of them are the same. They mean the same thing. The summary statistics of your entire cohort and also your initial results. So we have all three examples here. So in Rula's example of the resilience scale, it was a continuous variable. For example, CD4 count, or in Rula's case, the resilience scale result. So there were 10 questions. It got answered. The 10 questions got answered from 0 to 9, let's say, and then you added up all the results of the 9 questions, and you have an overall score, and that's a continuous variable. And as Rula said, that gets reported. The summary statistic technique to report a continuous variable is a mean and standard deviation, and or a median and interquartile range. And so the standard deviation is the number that where 95% of the data falls between plus or minus the 2 standard deviations. That's how you determine the standard deviation. And the interquartile, the median, oh, maybe I need to explain what does everyone know what the mean is? The mean is, it's the average. The lay term for mean is average. Let's take Rula's example.
What is interquartile? Sorry.
What's that?
What is interquartile?
Oh, I'm going to explain it.
Okay.
Okay. So the mean, what the mean is let's say in Rula's study of resilience, 10 women were enrolled. And the 10 women's different scores were 20, 75, 90, and so on. Do you see that? The mean is you add up their 10 scores and you divide it by 10, the number of women that were enrolled. And that's the mean, that's the average. Does that make sense to everybody? You probably do it every day. You calculate the average of something. Like what's the average number of hours of sleep I had this week? I had 4 hours on Monday. I had trouble sleeping on Tuesday night, so that was unfortunately about 3. And then last night I slept well, so I got about 8 hours. So I add 4 plus 3 plus 8, which equals 15, and then divided by 3. So on average, I had 5 hours of sleep in the last 3 nights. I want you to feel sorry for me. But so that's the mean number of hours of sleep I had in the last 3 nights. What is the median? So what you do for median is you put all of the answers that the women had of resilience in order. So you would put 25, 50, 75, 80. And the median is the value that is in the middle. So from 1 to 10, it's the value that is at the position 5. Do you understand what I mean? So using my sleep example, which is a bit easier, you would put the 3 numbers in order. So I had, what was it? I had 3 hours of sleep on Tuesday night because I couldn't sleep well. But then on Monday night, I had 4. And then last night I had 8. So what did we say that the mean was of sleep? My mean number of hours of sleep in the last 3 nights was 5 because it was 3 plus 4 plus 8, which is 15 divided by 3. But the median number of hours of sleep that I had was 4 because it's 3, 4, and 8, and the middle number is 4. Do you see that? And actually the sleep example is a good example because it shows you that there's often a difference between mean and median. And to you, which one is more accurate? Which one reflects more the number of hours of sleep that I had? Is it the mean or the median? What do you think?
Sorry, can you repeat that question?
In a way, they're both important. Do you see that? Because the 15 divided by 3, on average, I had 5 hours of sleep a night. So, that's maybe not that's not that bad. But the median is nice because it kind of gives you the more accurate interpretation of a value when the numbers are not normally distributed. When your different values are normally distributed, meaning they're kind of in a shape of an upside down U, then then the mean is actually the same as the median. But if they're not in the shape of a U, then the median kind of gives you the more accurate number. So I actually very often like to know both of them. But if you only had to choose one, I would choose the median.
And can I just add to that, Mona? So in Mona's example, when she gave her sleep hours, the reason the mean is not a very accurate measure is because it's influenced by extremes. So on 2 days, she had 3 and 4 hours, whereas the third day she had 8. So that 8 actually pulled the value up. And in a way, when you look at the median is 4, is actually a more realistic measure of her hours of sleep, because in fact she didn't really have great sleep. So the 8 kind of inflated the value, so because it's not normally distributed, so that's why we're better off with the median on that particular example.
Excellent, thank you. That's exactly it, Rula. That was super helpful. And so Kerrigan, what the interquartile range is it, you see, to get the median, you put your numbers in order from smallest to biggest. So for resilience, you put the 25, 50, 75, 80, 90, in order. And the 25th percentile is the value that is at the 25th part of the order. Okay, it's not easy to explain when you only have 10 women, but let's say we have 100 women who completed the resilience scale. Well, all of those 100 values that each one got, we would put them in order from the lowest resilience number to the highest resilience number, and then the woman at which number in the order would be the median. Who can tell me? Out of 100, there's 100 women, and you've just put their resilience scores in order. So the woman's numbers at which position is the median? Christian, can you answer that?
It would be the 50.
Yes! There you go. You got it. Yeah.
I didn't know whether it was a trick question. Like, I'm just trying to count. Okay.
Exactly. So the median for the resilience scores for the 100 women that you just put in order is the woman's score in position 50. That's the median. Kerrigan, another way that we call the median is the 50th percentile. Okay? So what's the 25th and 75th percentile? The score of the woman's resilience score at the 25 position is the 25th percentile, and the woman's score at the 75 position is the 75th percentile. Do you see that? And how the 25th and 75th percentile helps you is it gives you a sense of the range. So if the median is, let's say I looked at my sleep over the last 1 month, and my median is actually 7 hours of sleep, but the 25th percentile is down to 3, and my 75th percentile is at 8. It shows you it gives you a sense of the range, that the majority numbers of hours of sleep I'm having is between these numbers. Does that make sense now?
Yes, thank you.
But the simplest way to actually understand it is taking the example of 100 women who completed the resilience scale. You put their values in order. The median is the value that's at the 50th point, and the 25th and 75th percentile is the score at the 25 mark and the one at 75 mark. Okay, does that make sense? Any questions about that? That's the hardest one because categorical variables are relatively easy. An example would be gender. So for gender, we would have, as an example, do you identify as a man, as a cis man, cis woman, trans man, gender non-binary, gender queer, gender questioning, or other. So those are different categories. And you report them as a frequency and a proportion. So in the example of 100, the frequency is 10 identified as a cis man, 25 identified as a cis woman, 30 identified as a trans man, and so forth. So that's the actual number. And the proportion is, if it's out of 100, if 100 people enrolled, then the frequency is the same as the proportion, but the proportion is the percentage. So you always report a categorical variable with a frequency, which is the exact number, and the proportion, which is a percentage. Okay, so that's how you report the summary statistics. So here we go again, explaining it a little bit. The same thing that we went over. The mean is the average. You add up all the numbers and you divide them by how many there are. The median is you put the results in order from smallest to biggest, and you take the middle value. And the mode for an outcome with categories is the category that occurs most often. I didn't know that, but it's on the slide. There you go, a little bit of information, new information for me. I forgot that about the mode. Okay, what else? So do you see how the type of variable we have for our outcome dictates how we summarize it? Not only does it do that, it dictates what test we use to compare two or more groups. So let's take Rula's example of resilience, because it was a continuous variable. And this is really interesting from Rula's study. It turns out that trans women had higher resilience scores than cis women. Okay, but we want to calculate a p-value. Like you calculate what's called an effect size, like how much greater did trans women, how much more resilient were they compared to cis women? That's the effect size, and then we're going to calculate a p-value about that, and you know, how how true is that value. And for continuous variables, the comparison, if the outcome is a continuous variable, we compare the means. So the mean value of the resilience scale between group 1 and group 2, and the test we use is called a two-sample t-test. Here, however, in Rula's example, she used medians, and so so you can compare medians of group 1 and group 2, and the test that you use to compare medians is called a Wilcoxon rank sum test. So you again rank them up in each group, and then you do the comparison. That's a bit more advanced. I don't have that in these slides, but you seem like a really advanced group. So not only does the type of variable tell you what type of summary statistics you're going to use, but it also tells you what test you're going to use to compare groups. And if it's a continuous variable, you use a two-sample t-test, or you use a Wilcoxon rank sum test. if your variables are a dichotomous variable, so for example, here's your example, Christian, the viral suppression, percentage of people with viral suppression, group 1 versus group 2. So you compare the proportions in those groups, and the test that's used to compare proportions is called a chi-square test. You're an advanced group, so there is another test you can use, which is called a Fisher exact test. And we use Fisher exact tests if the frequency in one of the groups is very low, is below 5. Is 5 or below. So see here in these two groups we have 400 and 300, but if one of them is 5 or below, the test you would use is called a Fisher exact test. See, this is like advanced, that's like statistics 201. So all you really need to know is we use a t-test for continuous variables to compare between groups, and we use a chi-square test to compare your outcome result, your proportions between two groups, if it's a dichotomous variable. Does that make sense?
Yeah. I was just wondering though, Mona, just thinking and listening and stuff, is there a good reference book if I wanted to learn more about the different tests or something that we could get? Like you can think about it and answer later or something.
I don't have one. Because to tell you that, like, I find statistic books. That's why I've done this presentation, because I find them really complicated. If anybody has an article or book that they find really helpful to explain all this, let us know. Anybody have anything?
And I'm just weird. I like to read up and understand that kind of stuff. So I guess the answer is no.
There are tons of statistic textbooks. I find Wikipedia very helpful. So you can you can Google t-test, chi-square, different things. Yeah.
That's much cheaper anyway.
I do have to say, I think, Mona, your presentation is the best so far of all these stats classes I've gone through. So thank you.
Oh, thank you. You're welcome. I'm trying, everyone makes it so complicated, but it's really not that hard. Yes?
I have a suggestion for a really good website that I always go to. It's called Choosing the Correct Statistical Test. It's by UCLA. Basically, I just Google which statistical test to choose, and it's like the first website that comes up.
Oh, good to know.
Yeah, I can send around the link maybe in an email.
Okay, thanks so much, Ivana.
No problem.
Okay, what is the p-value? We're always talking about the p-value. The p-value is the probability of the observed outcome if there is no difference between the two groups. So we arbitrarily set it at 0.05. So let's say we do find a difference between the two groups. So for example, resilience is higher in trans women versus cis women. And let's say our p-value is 0.04. What is the chance that difference that we found is actually not real? It's actually there is actually a 4% chance, because if we repeated the study 100 times, 96% of the time we would find the same result, but 4% of the time we would find no difference. That's what the p-value means. So the lower the p-value, the more likely, the more accurate what the difference that you found is actually real. So so if you have a p-value of 0.01 and you repeated your study 100 times, the chance that what the answer is that you found is wrong would be 1%. So the lower your p-value, the more likely that whatever your association is that you found is actually accurate. Okay? There is actually a big discussion right now in the statistical world whether the p-value should be moved to lower than 0.05. I'm not sure if anyone has seen that literature. There is some discussions to move it to 0.01. Why did we arbitrarily choose 0.05? Maybe a 5%, something being 5% chance of being wrong as a association, maybe that's too high. So choosing the p-value at 0.05 is arbitrary. And so think about that when you're looking at your analyses. If you have an answer that is with a p-value of 0.001, that association is more accurate. Now, a p-value of 0.001 means that your association is accurate, but it doesn't address anything regarding bias. So I want to be clear about that. It just tells you about the accuracy of the association that you found with your data set. But it doesn't mean that it corrected for the bias. For example, let's say in Christian's analysis, it doesn't correct for the bias that we didn't include all those people that weren't in care. It can't correct for that. It just means in the data set that you have with the research question that you asked, the association that you found is very, very accurate. And it's likely that it's true because the p-value was 0.001. And the chance that that there is an association is 0.1%. So it's very low. Do you see that? But if this p-value was 0.05, there's a 5% chance that if we found an association, there is a 5% chance that association that we found wasn't true. And actually, the truth is that there's no difference. Okay? And so you have to sort of take p-values with a grain of salt because it's arbitrarily set at 0.05. I also take it as a grain of salt in the other direction. And actually, Rula and I ran into that with her study. So you can have a association that's really strong, so and interesting to you. However, the sample size wasn't high enough so that the p-value went below 0.05. But it doesn't mean that the result you found and the association you found isn't important. That association might still be of importance to you and could have value, and it could trigger you doing future studies in that area with larger sample sizes. So don't ignore associations that don't have a p-value less than 0.05. You have to look at the importance of them and the effect size of them also. So so that's an important concept of looking at everything and looking at p-values that are below 0.05 and even above. Is that helpful? Make sense?
Yes.
Okay. So the outcome, again, is your dependent variable. The independent variable can also be called the exposure predictor. It can also be called the correlate. And as I said, all of statistics is finding an association between the exposure and the outcome. And so in Christian's case, his exposure is a composite variable of privilege, and his outcome is viral suppression. What is a confounder? And see, this is from Wikipedia. I love Wikipedia. It's an extraneous variable in statistics that correlates with both the dependent variable and the independent variable, and a perceived relationship between an independent variable and a dependent variable that has been misestimated or misinterpreted due to the failure to account for a confounding variable in terms of a spurious relationship and the presence of misestimation for the reason in terms of omitted variable bias. So let's go back to the example we used with Christian, because I think it's a good one, where we said his independent variable of interest is privilege and his outcome is viral suppression. If we didn't include social support, which is something that could be associated with the independent variable and the dependent variable, there could be a bias there. There could be a spurious result, and we have to include it. That's maybe not a good example because we don't have social support, Christian, in the data set. But if there is a potential confounder that's really important, then you would again include, and we don't have the result, you could include it we would include it in the limitation section of the paper. Okay. The thing is you can get what variables you think are going to be confounders from looking at the prior literature. So we know that the variables that correlate with viral suppression, Christian, include baseline viral load, so how high the baseline viral load is. Age is often correlated with viral suppression. And then the other one that is often correlated is injection drug use. So, which we would be capturing with HIV risk factor in your composite variable of privilege. And then, Christian, in your example, you asked you were interested in hepatitis C.
Yeah,
what you're gonna find, okay, is there are different independent variables that are what we call collinear. And so if one variable is collinear with another variable, you don't include both of them. So hepatitis C is actually collinear with injection drug use. And we have statistical ways to see if two variables are collinear and which one is more associated, and we include the one that is more associated. So if you include, the reason I said don't worry about hepatitis C is because hepatitis C always turns out to be collinear with injection drug use. And so we end up including injection drug use and not hepatitis C. And so that's a reason why. Okay, is that helpful?
Yes.
Okay. Much of statistics is done to determine if our results are true and to eliminate confounding. And there are different methods that we use to handle confounding. What are those methods? Here they are. We use something called stratification. So you can ask a question like, Christian, you're interested in variables of privilege. And you know what, Christian, you know my work. I'm very much interested in gender. So I could ask you, I think the results are going to be different for men and women, and I'm going to include trans people as they identify. So that would be cis men, trans men in one group, and cis women and trans women in one group. So I think they're different. So you could actually stratify your analysis by gender and do the analysis for men and do the analysis for women. And then that corrects for the confounding of gender. You see that as a method of handling confounding. I'm not sure you know, but my expertise is in clinical trials. And so randomized controlled trials are considered the gold standard of handling confounding. Why are they the gold standard? Because a randomized controlled trial has the intervention of drug A versus drug B. That's our intervention of interest versus the comparator. And then we randomize people. So we, at the flip of a coin, the 100 people go into group A or group B. So there's 50 in one group, 50 in the other. And what happens is the confounders, known confounders and unknown confounders, are distributed equally because of the randomization. Do you see that? So the age will be random. Whether they smoke, whatever their baseline viral load is, gets split evenly because they're distributed randomly between the two groups. But not only are those confounders that we know are randomized, but there might be confounders we don't know influence the outcome. Those are randomized also. And that's why randomized controlled trials are the gold standard for handling confounding. And that's why RCTs are used, for example, for FDA labeling of drugs. The method, Christian, you are going to be using to handling confounding is called regression models, regression analysis. Okay? And this is where we're going to get to answering the question you had, but how do I handle my composite variable and all of those different factors? It's with regression analysis, Christian, okay?
Okay.
So I I put an asterisk. It's the method that's used most commonly in CANOC is regression models and analysis. So what is regression models? It's used to describe the relationship between an outcome variable and one or more predictor or independent variable. And we tend to call it in a regression, we call them covariants. And so I told you that we want to identify what type of variable our outcome is, to identify what summary statistics we're going to use for that variable, what test we're going to use for comparison, which now we know from Irona we can find at the UCLA website. But we also use what type of outcome we're using to determine what kind of regression model we use. Okay, so if our outcome is a continuous variable, we use linear regression. If our outcome is a binary variable, we use logistic regression. And if our outcome is a time to event variable, we use proportional hazard regression, and another term for that is Cox regression, COX. So you see in your analysis, Christian, you are going to be using logistic regression for the binary variable if viral load less than, in CANOC, it's less than 200, yes or no. And then for the two questions of time to viral suppression and time to rebound, you're going to be using proportional hazard regression. Do you see that?
Yes.
Easy. And
Okay.
yeah, and for Rula, she used linear regression. Okay, linear regression is when the variable outcome is a continuous variable. And here, height is the outcome, which is obviously continuous. You have a constant called B0, And so the regression model is just a formula. Okay? So B0 is a constant, and then B1 is the coefficient associated with your independent variable of interest. So for age is your independent variable of interest, height is your outcome. You put it in the computer and it's out the result. So for every year which is your independent variable, the height increased by 10 centimeters, and that's your coefficient. Okay, let's look at logistic regression. Same thing. You have your outcome, which is like here. Here. You have your outcome. I should draw it better. You write the formula, which has outcome equals your B0, which is your constant, plus your B1, which is your coefficient associated with your first independent variable of interest, age. And so this is where it comes in, Christian. You can do your logistic regression for one independent variable of interest, age, but the way you correct for confounding is you do your logistic regression with all the variables that you're interested in including. So you do age, you do gender, you do number of antiretrovirals, or in your case, you do ethnicity, you do HIV risk factor, you do income by quartile based on postal code. I can't remember what else we had that you were interested in, but those are the three that I remember. And
ethnicity and age, yeah.
And age. So age, ethnicity, HIV risk factor, and you might want immigration status, but I don't know if we have that. I guess that'll be captured in ethnicity. And income, quartile by postal code. So those are your variables of interest. And you have your constant, and then you have your coefficient in front of each variable that you're interested in. And Christian, this is what regression does.
Mm-hmm.
It corrects, and then so the result you get, the coefficient result you get, is the association, which is the odds ratio for logistic regression. And when you put multiple variables into your model, your coefficient is adjusted for the other variables in the model. Okay?
Okay.
So you could put age alone, and the association between age and viral suppression between people who are over 40 and under 40, let's say it was 3. The odds was 3. People who were over 40 had 3 times higher odds of having viral suppression than people less than 40. But when you put gender, number of antiretrovirals, all those different things into your model, it adjusted the odds ratio from 3 to 2, and that is because it adjusts for the associations between age and gender, number of antiretrovirals.
Mm-hmm.
So we correct for confounding using regression analysis and putting the multiple independent variables into the models that we're interested in determining the association. So you will be using logistic regression, and then for the other 2 outcomes, which are time to event, you will be using Cox regression. And again, you have the outcome of time to event, and then you put in all the independent variables into the model that you're interested in analyzing, and then your output and effect size, which is here, which in Cox regression is a hazard ratio, And so this value 2 is adjusted for all of the potential confounding of the variables that are put into your model. But you see what the problem, why regression analysis isn't necessarily ideal. If you don't put an independent variable or covariant into your model, you could be missing confounding, right? You have to put the variable into your model. That's why randomized controlled trials is the gold standard, because you're randomizing known confounders but also unknown confounders. So here in a regression model, all you're correcting for in terms of confounding are known confounders, because you're the one that puts in what variables you want into your model. Okay, so we run univariate models, so you can do a regression analysis just for age. Okay, and then we do multivariable models, which we described, which is what you're going to do, Christian. That's how you is one of the ways to manage all of those different variables. There's some other ways we can talk about. We can do something called a propensity score. So we could actually take those factors that you're calling factors of privilege, and we can make a propensity score. So we can combine them all so that it becomes one covariant of interest, one independent variable, and it gets reported as a propensity score. So we can talk about that. I think that would be really interesting. But technically a propensity score is a type of, it's in between univariate and multivariable.
Mm-hmm.
But most commonly we would look at all of the independent variables of interest or covariance association with the outcome in a univariate way, and then we would build our multivariable analysis with multiple of covariance in the models. So we went over this already a little bit. Lack of statistical significance may be due to lack of an important difference, fine, but it might also be due to an insufficient sample size. So don't necessarily completely disregard that your finding. It might be a good trigger to like, oh, this is an interesting finding to further analyze that association. If something is statistically significant, it may be important statistically, but it might not be clinically significant. It might be clinically insignificant. So you might find an association, but if it really doesn't have that big a deal on people's lives, people won't be interested in it. You also can have statistically significant results if you do a lot of data dredging. So the more number of comparisons you do, the higher the chance that you're going to have a p-value of less than 0.05 just by chance. Other points to consider: sample size, we talked about a little bit. Generalizability. So your result, Christian, is going to be generalizable to other countries that are resource rich or high income countries, but it might not be generalizable to low and mid income countries. Do you see? So that's about generalizability, biological rationale, appropriate study design, adequate presentation of data, and how are we going to handle missing data. And so that's it. That's the end of the Statistics 101 talk today. I hope it was useful, and we can stop the recording and maybe talk a little bit about what kind of topics you want to review for the next webinars.
Great.
Any questions before we stop the recording about statistics? Okay.
Mona, just one quick question. I think I think what asked earlier, and I'm not sure. I find this presentation really helpful. Thank you. So in terms of, let's say, my question, do I still need to come up with the comparison groups, or do I not have to do that because I'm already using a composite variable, and I'll be using the multivariate regression and the Cox regression? So does that kind of take out the fact that I need to have comparison groups?
Okay, so let me explain it to you. I have the slide up about the research question here.
Yeah.
PCOT was really developed for clinical trials, Chris. It was developed for randomized controlled trials. So you have your population, you have your intervention, which is drug A, and your comparison, which is drug B. Okay? And then you have your outcome and time. We're trying to take PCOT and use it for cohort analysis, but it doesn't totally fit, because you have your overall population, which in your case is all people living with HIV that have enrolled in CANOC, right? And your outcome is viral suppression. The independent variable of interest and the comparison are together. Okay, they're the same thing, because your independent variable is, let's say, ethnicity. Well, your independent variable ethnicity is, let's say, the particular ethnicity that you're interested in is ACB populations, African, Caribbean, Black populations. Okay, the comparator are all the other ethnicity, or maybe your comparator are all ethnicities other than Caucasian. So ACB ethnicity, indigenous, other ethnicity, and your comparison is Caucasian. So technically, the way that the research question gets confusing for cohorts is that it's really developed for clinical trials, and the independent variable and the comparison are actually together. They're the same thing. And it's just the independent variable of interest is which part of the independent variable are you most interested in? So I think for example, for ethnicity, you're interested in all of the ethnicities that don't have privilege. So that would be ACB, indigenous, and other, and your comparison is Caucasian. Or your other independent variable you said was risk factor. So you were interested in, MSM being as the category of privilege in risk factor. So MSM would become your comparison, and your independent part, the part of that independent variable that's up here would be injection drug use, heterosexual contact, endemic country. Do you see that? They're actually they're combined. That's one of the things that's a little bit confusing.
Okay, great. Okay. Thank you.
Is that helpful? Does that explain it? Are we still there? Or the time is out?
No, that was perfect. Thank you, Mona.
This is actually...
So is everyone, does anyone have any more questions, or is everyone comfortable with me finishing my recording now? Okay, so I will take that as we can turn off the recording.